Схеме радиотерапии при лечении анального, ректального и рака мочевого пузыря.
So good morning everybody. On behalf of Professor Fietkau, who has unfortunately a cold and had to stay in Germany, I'm telling you something about hyperthermia in combination with radiotherapy and chemotherapy in anal, rectal and bladder cancer. First, a few informations about hyperthermia. Hyperthermia is the heating of tumor tissue in the temperature range between 39 and 44 degrees. We apply treatment times around 60 minutes. And what is also known is that hyperthermia is a potent radio and chemosensitizer, which means that we have an impair in DNA repair. And in the context of a chemosensitizer, we can increase the blood flow inside the tumor. Another aspect is that hyperthermia activates the immune system. So I would like to give you now some research papers, for example, from Wiener on superficial hyperthermia. And what he did is he treated patients only with radiotherapy and radiotherapy plus hyperthermia, and what he found on breast cancer is that he could control the local, could improve the local control of breast cancer around 20 to 30%. In another example, cervix cancer, he could also improve the long-term survival of around 20%. And at the hospital in Erlangen, we use a ESD 2000 device, which is combined with a magnetic resonance tomograph to control the temperature. And by way of example, you can see here a soft tissue sarcoma, and the right one is the high temperature in which we have the tumor, and we control very good the temperature. Another method besides superficial hyperthermia is interstitial hyperthermia, and we can inject the applicators inside the patient. We do this, for example, in head and neck cancer or prostate cancer. And I want to give you now some details about the studies that we do in Erlangen, and most of them are multi-institutional studies. The first one is rectal cancer, the so-called Hyrex study. The second is anal cancer. There we have some retrospective data and a prospective study. And the last one is bladder cancer, in which we try to spare the transplantation and the surgery. So the first study is the Hyrex study. This is a multi-institutional phase 1, phase 2 study. And this has the seal of approval, which means that it is reviewed by an independent commission and accepted and according to international doing so. This is a neoadjuvant chemoradiotherapy with deep regional hyperthermia in locally advanced or recurrent rectal cancer. And the study is designed, this is, as I've already said, a multi-institutional phase 1, phase 2 study. And we decided on the feasibility of multimodal machining consisting of radiochemotherapy and hyperthermia. And the sample size was, in the first decision, the feasibility, and we needed 59 patients. And the second one was the efficacy, in which we needed 110 patients. The total recruitment time was 2.5 years, and the follow-up of 5 years. And we had two endpoints. The primary one was the feasibility, in which we focused, for example, on the toxicity, the pathologic complete remission for the efficacy, and it is very important that we can apply at least 7 out of 10 hyperthermia appointments. And the secondary endpoint is local progression-free survival, overall survival, rate of curative resection, and the rate of acute and late toxicity. Here you can see our treatment plan. We irradiated the patients 5 times a week for 5 weeks and did this in addition. we gave the patients 5-FU and oxaliplatin and did deep regional hyperthermia 2 times a week. Here you can see that we made out of the necessary 110 patients, we already have recruited 93 patients and 17 are still missing. And the participating centers are Erlangen, where I come from, Munich, Bad Rissels and Tübingen. And as you can see here, we already did the primary endpoint number, which was 59 patients. And the first results are evaluated with 63 patients. We had 10 with locally advanced cancer and we had 10 with recurrence and 53 with advanced rectal cancer. In the first results, depending on the toxicity, we only had grade 2, grade 3 toxicity. They were all caused by chemo and radiotherapy. And what's very important is that all the patients recovered again. So the treatment was very well planned. And when we talk about the applied hyperthermia appointments, we had the endpoint that we need at least 7 out of 10 treatments, and we did it in around 94%. Another thing that we observed was the toxicity, regression grading according to TERAPIYA, and we focused on grading 3 and 4, which means that we only have scattered tumors or no more little tumor cells inside the patient. And here you can see that we had the grade 3 and 4 in around 64.3 patients. We had no grade 4 toxicity, and as I already said, we had a number of treatments, more than 7 hyperthermia in 94%. Then the second study is on eye cancer. There we had some retrospective data and some prospective studies. Here you can see a retrospective analysis, more than around 30 years in 112 patients. And you can see the difference between chemo radiotherapy and hyperthermia, which we did in 50 patients. We had a local recurrence-free survival of 98% in comparison to radiochemotherapy, where we only had 79%. The overall survival was also much higher in patients treated with additional hyperthermia. The HYPEN study is also a study in anal carcinoma, and it also has the CRED approved from the German Cancer Society. This is a standard radiochemotherapy with 5-FU and mitomycin in deep regional hyperthermia. And here you can see the treatment plan. This is the control arm without hyperthermia, and in the experimental arm we had 6 sessions of hyperthermia. And we also did some blood collection to do some immunophenotyping in our labs. We recruited at the moment 26 patients out of 110 in the participating centers of Berlin, Tübingen and Erlangen. This is the third study I want to talk about. It's on bladder-sparing treatment. And this is a very interesting graph because you can see in the 1990s we always, more or less, we did a lot of radiotherapy and it changed to radiochemotherapy. And since 2004 we do most of the treatments by radiochemotherapy in addition with hyperthermia. Here's the treatment plan. And we also did a so-called multivariate analysis in which we observed the differences between the different treatment strategies. We had radiotherapy, radiochemotherapy, and radiochemotherapy plus hyperthermia. Also focused on age, primary treatment, recurrence, R classification, and so on. That are results from the disease-free survival. You can see that treating patients with radiochemotherapy and hyperthermia led to much better results, and the overall survival was also better. What is very important, what I said at the beginning, that we try to avoid a secondary cystectomy, and this could also be found, that hyperthermia is better for the patients. And when we compare this with other papers, we can say that the 5-year overall survival when we do radiochemotherapy plus hyperthermia is higher than doing radiochemotherapy without hyperthermia. And so to conclude it, we can say that hyperthermia in combination with radio and chemotherapy is feasible and does not increase toxicity. We only have grade 2, grade 3 toxicity. And in retrospective analysis, we observe better results in bladder cancer and anal cancer. And the third point is that we try to do some prospective multicentric studies in the future.
Спасибо большое. Очень интересная лекция. Насколько интересно, можно один вопрос? Ну, вот мы тоже занимаемся гипертhermiей, не только я, но и ряд исследователей занят. И мы пользуемся принципами, разработанными давно еще Овергатом, когда влияние сенсибилизации гипертермической при лучевой терапии наиболее высокое тогда, когда гипертермия проводится ближе всего по времени к лучевой терапии, либо до, либо после. И со временем сенсибилизация, если мы будем дальше проводить гипертермию, ее сенсибилизирующий эффект будет меньше. Вот у вас разница в температурах 39, 44 или 45 градусов. Вот зависит у вас последовательность применения гипертherмии и лучевой терапии от температуры, которую вы создаете в опухоли. Вот по нашим понятиям, значит, вот как мы это делаем сначала, мы, вот если мы не догреваем, нам представляется, мы меряем, у нас нет объемного представления температуры, то мы тогда делаем гипертherмию до лучевой терапии. Если у нас высокая температура, то тогда гипертherмию проводим после облучения. Почему? Потому что все-таки вот есть вероятность того, что если мы разогреем опухоль после облучения, что это усилит кровоток и выброс опухолевых клеток в кровь. Спасибо.
Yeah, I understood it. But I'm not so familiar with the treatment plan. Maybe the microphone.
So in terms of the timing of radiation hyperthermia, I believe the key is that we're putting them as close to possible time-wise as possible. In regards to the concern about blood flow, and not sure if you were implying that there may be metastasis because of spillage of tumor, but as we know that it's not enough for a tumor cell to get into the circulation. It must have a range of capabilities to get into not just the bloodstream, but out and start to grow. Our approach has been looking at the logistics, and I have done it both before and after, both with very good results, and have not seen issues with metastasis.
Thank you for being short and direct.